probably want to change gears because this is such an important topic. So here we are, we're at ASCO, hearing amazing things. The human immune system is actually capable of recognizing and killing cancer, that we understand the molecular basis of cancer at a level we never did before, and there's all of these access and diagnostic and therapeutic interventions that every oncologist is going to want to go home and offer to their patient, and that's going to cost money. So how do we support this? How do we pay for this as a nation? Innovation, research, without, quote unquote, adding to the total cost of care, which you defined in the first segment as a big problem. Mike, I'll start with you.
I think the answer, Andrew, is that we should be really focused on making sure that the right patient get the right treatment. And there's a strong belief, and I think every oncologist who practices knows this, that there's significant waste in the system. I mean, there's things that we do that we know are going to be either it's not going to work, or that patient doesn't need that scan, or there's a lot of stuff out there. So Berwick says 30%, right? 30% of care is wasted. So
right.
That's a lot of money in oncology. That's a lot of money to free up. I think that as we think about how we implement these novel therapies, I think we should be critical of the quality of the evidence, that it is truly efficacious. We should be critical about what constitutes real benefit, and to the extent possible, we should promote our research colleagues. We should encourage them to focus on biomarker development, trying to find ways to determine, who should get what treatment. That's so key. I mean, just think about it for a second. If we decide, for example, the checkpoint inhibitors are good for everybody with lung cancer, and I'm telling you, it's not that far in the future, right? That's my opinion. But so I did a little math, right? And the number of new lung cancer. Just wait a second, right? So there's 220,000 new lung cancer patients a year. 220,000. 85% of them have a diagnosis or develop metastatic disease, 85% of them. If each of them get a year of therapy with a checkpoint inhibitor, it'll cost $28 billion. That's the sticker price of nivolumab and pembrolizumab for a year.
Right.
That's not what we pay.
Right.
That's not the +6
right.
or +12 or plus whatever. That's the $28 billion, of which, based on the data that's published so far, let's be generous, a third of them will be long-term survivors. That means 70% of them won't, which means that $21 billion will be used to treat patients who ultimately will not benefit from the therapy. So all I'm saying is, if you just think about that one thought experiment, then we got to think a little bit about, it's way better if we can identify the people who really, really benefit. I'm really excited, for example, about this the checkpoint inhibitors and mutational burden, and I think that is so cool.
Yes.
Because all these meetings I go to and I hear about immunohistochemistry, and I sort of chuckle, right? Because, God, immunohistochemistry, we were in medical school when immunohistochemistry was the test du jour. And
right.
That's just nonsense. I mean, immunohistochemistry.
So we're going to move on to the next subject, but I think what you're supporting is the concept of the Goldilocks formula. Not too much, not too little, just right for the patient. So the other big discussion point is how health exchanges and private plans are impacting on oncology practices. So, the legislative issues that are going into this, the Medicare Access and CHIP Reauthorization Act, how will these initiatives, starting with you, Jeff, how would these initiatives affect your practice?
Well, I think we have to understand that these initiatives are not healthcare reform; they are insurance reform. Many of what's happening is that there are patients who now have access to the system who didn't have as good of access before. And those patients are coming to practices and coming to hospitals. Many of them are still underinsured. They had a choice when they decided to develop what was an acceptable insurance plan. They could make it cheap or they could make it good, and they made it cheap. And so many patients are still underinsured. Those patients end up in hospital-based systems in large part because private practices still can't afford to take care of them. I think that it's been a boon for hospitals because they were taking care of those patients in the first place and getting paid nothing, and now they're getting paid something. I'm not sure that it's changed the landscape in private practice at all, though I'll admit I'm not in that place right now.
Although the SGR fix clearly is going to encourage people to explore alternative reimbursement models because they'll get paid better
That's right.
if they do. And I think whatever you think about the ACA, and I am a non-political person, it's done some good things for cancer patients, right? So screening is covered with no copayment. That is a wonderful thing for cancer patients.
Yep.
There's no pre-existing condition. That's a great thing for cancer patients. And there's a max out of pocket. Now that's also a really good thing, but let's remember what that means is that catastrophe, financial catastrophe can be avoided. But if you're making $40,000 a year, one could argue that $6,000 out of pocket is a catastrophe,
Yes.
and I'm not insensitive to that. But so it's done some good things. One of the parts of the ACA that really didn't get as much attention, but we're seeing it now, is the charter of CMMI to start looking at and exploring alternative models. So you can like or not like the OCM, but the OCM is going to be a potent catalyst for change.
Absolutely.
Practices are actually starting to think about processes of care, whether they get the CMMI money, and honestly, if I were in practice, I'd want that CMMI money. It's $1,000 for 6 months of care that I wouldn't have otherwise, right?
Right.
And they are stipulating what they consider to be components of that optimal patient experience. Now, maybe they're right and maybe they're wrong, but there's nothing on their list that you would say, oh, that's nonsense. Everything on their list, you and me, we'd say, there's a kernel of truth in that, whether I like the way they put it or not. So I think we're starting to see a clear migration to alternative payment models, which is being catalyzed initially by the ACA and now by the SGR fix.